Yeah, so I want to just step back to something David touched on, is that right now the predominant drug out there is fentanyl that we're treating. And the risk of overdose death is just enormous because we really don't know what's in the fentanyl. That's being, there's xylazine. It's just very, very dangerous. So I think MAT, or medication assisted treatment, has a very important role. That could be methadone, that could be Suboxone or buprenorphine, and that could be naltrexone, which is the pure opiate blocking medication. So I think there's definitely a place right now for all three of these, especially with the risks of fentanyl. I think, and David touched on this, one thing that's really, really important is to determine what's the need of the individual. So when you first meet this patient, what do they need? Where are they now? Are we just treating and preventing, the use of fentanyl and overdose death? What are their immediate needs? And then you can look at each of these different treatment options and figure out what best meets the need of the individual. So are we just trying to are they in withdrawal and we just need to stabilize it? And then going forward, do they want to use these drugs to detox? Is there a reason for a period of time to be on a maintenance dose to stabilize the rest of their life and, their environment and everything else? So I think we really have to understand the individual. And then, as David's talked about, a lot of the patients that I treat have now they've been on these meds for a period of time. They're stabilized and they just no longer want to be on maintenance meds. They want to be opiate free. We often hear of methadone being the liquid handcuffs. So patients, they've been stabilized, they're on it, they've tried to wean off on their own. They can't tolerate the withdrawal. They're just not achieving their goals. So I end up meeting them and treating them because they just want to be off these medications at some point. So I think, and then the other thing is you touched on training. When I see patients on Suboxone, a lot of them are on a much higher dose than was needed to treat their original opiate issue. My adage has always been start low and go slow. So you really want to, when you're initiating these treatments in patients, you really want to find the lowest effective dose to achieve your goals. And then, like I said, have the discussion. Are we going to use Suboxone or methadone to wean or detox? Is it going to be a maintenance? So I think the most important thing is to really understand what each individual patient wants or needs at that time, and to really tailor the treatment to their wants and needs.